Hi everyone, I want to talk about psoriasis treatment. Okay, before you embark on treatment, you will have to consider some selection criteria and factors to be considered before selecting medications or route of treatment are: how severe is the disease? Are there psoriatic arthritis present? What is the patient's preference? How much does it cost? How easily could this be administered? And would there be a problem with compliance? Are there any associated comorbidities in this patient, like cardiovascular disease? Any diabetes mellitus here? Is this person having other autoimmune diseases like inflammatory bowel disease? For example, somebody having inflammatory bowel disease and you are giving oral medications, could you predict whether this is going to even stay in the gut before being administered or not? And would this actually help the autoimmune condition in this person as well? Then alcoholism, that will affect the metabolism, smoking for the same purpose, anxiety or depression, that the person will not even remember how to take this medication. Be certain that correct diagnosis has even been made in the first place. Then region of the body affected, and of course, truth telling will be to your own advantage because it's going to foster trust now between the caregiver and the affected individual. And the truth here is there is no cure, but it can be brought under control and for cosmetic reasons. What are the possible choices we can make when it comes to psoriasis treatment? It could be topical therapy if it's affecting small areas, or phototherapy if it is moderate or severe. Systemic medications could be involved if it is moderate or severe. So if it is mild and small area, topical therapy should be tried first. When it's affecting the hand, the foot, the face, and joints, then we need to pay more attention and embark on aggressive therapy. Let me go over some selected patients because I'm not going to treat everybody the same way. Pregnant. Oh, there we go. We use only topical steroids and not for a long period of time. You can use a tar or topical salicylic acid. We have to contact the dermatologist before we can administer phototherapy, Adalimumab, Infliximab, or Etanercept. We have to contact dermatologists. In fact, when you are talking of phototherapy, no ultraviolet A, but you can use ultraviolet B. And you can never use methotrexate. By the way, do you want to abort the pregnancy? You get sued. No methotrexate, no psoriasis ultraviolet A. But before you can use ultraviolet B or disease-modifying anti-rheumatic drugs, Adalimumab, Infliximab, or Etanercept, contact a dermatologist. Maybe in addition, send consult to OBGYN specialist, obstetrician, that this is happening to my patient and this one the dermatologist has advised. Kindly advise as appropriate. Okay, we are out of the pregnancy and the pregnant women. Now, every other human beings, and the psoriasis is found on the face of Flexures. Add a cortisone 1% cream at hour of sleep, but not for a long time use, please. Phototherapy or early death, that is tacrolimus or pimecrolimus, that is calcineurin inhibitors, for a short time, as small as dose possible. You can add adifunga, now, proconazole or lamisil, terbinafine, and keep the folds very dry. This is affecting the hands and feet. Remember, I said you're going to pay more attention and become more aggressive. I'm not saying you should be fighting. Somebody heard the word aggressive. Oh, great. I'm going to punch. No. If you do that, you get sued. Use your TAG, use topical corticosteroid, Dovobet, that is combination of calcipotriol and dexamethasone. At hour of sleep, you administer this. And the first thing in the morning is to wash. You can use some other medications I'm about to list, but you have to contact your dermatologist before you start. That is tazarotene, amtralin, TAG, calcipotriol, phototherapy, oral retinoid, and methotrexate. They are fine, but contact your dermatologist first, please. Yes, psoriasis is found in other parts of the body. You can use Dovobet, TAG, amtralin, tazarotene, phototherapy, methotrexate, Biologics in the form of Infliximab and the rest. Contact your dermatologist for guidance, please. Somebody is whispering then, why do you want to even do it at all? The reason why we want to do it at all is not all the time you're going to get a dermatologist. Some communities, about 3,000 to 500,000 people might not have more than 2 or 3 dermatologists at a time. So if you have the knowledge of what to do and you just message them, maybe send picture, then you're likely going to be guided and then get it done, unlike just referring and the person is waiting on waiting list for 1 year and the individual is suffering. Okay, so it's good you equip yourself and you can help your patient. You can also choose from anti-tumor necrosis factor. I've mentioned Adalimumab before, Etanercept, Infliximab, and the likes. Calcineurin inhibitors, tacrolimus, and pimecrolimus. We can use cold tar shampoo, tazarotene, amtralin photochemotherapy like psoriasis plus ultraviolet A. Methotrexate, emollients, topical steroid, climatotherapy. I'm going to go over that later on and make a separate presentation fully on that. That is bathing in seawater. You bathe in seawater, then you have yourself exposed to sunlight. It's therapeutic when it comes to psoriasis. When you bathe in ordinary tap water and you expose yourself to sunlight, you're going to get less effect compared to bathing in seawater and exposing yourself to sunlight after. Retinoid, cyclosporin, apremilast, that is phosphodiesterase 4 inhibitor, are all very helpful when it comes to psoriasis treatment, but you need to contact the dermatologist or at least get him or her informed and you'll be readily guided. Okay, with that, I've come to the end of psoriasis treatment. Kindly subscribe to my channel so that you can get these presentations immediately they are published. Thank you. I appreciate it.